Daria, for joining, and we are quite excited to hear you talk.
Many thanks for this introduction, dear Professor Reiner. And first of all, dear colleagues, I would like to express my gratitude for inviting me to join this important professional event, the second conference of the Global Psychiatric Association. And I hope I will shed some light on the words and actions which should be spoken and done related to schizophrenia and treatment of our patients suffering from schizophrenia spectrum disorders. Here I represent, as Professor Reiner kindly mentioned, the International Center for Education and Research in Neuropsychiatry, which has been organized in our university 2 years ago. And the information about some advertisement, the information about our center has been published in the World Psychiatric Association review, and have been supported by the president of the World Psychiatric Association, Professor Afzal Javed, and the general secretary, Professor Peter Morozov. And actually what was new from our country is that we have been first who employed foreign professors on remote contracts to our international team of the center. And this slide I would like to show in the memory of our dear Professor Peter Morozov, who is my mentor, my tutor over the last more than 10 years. And he was really and is really still the source of inspiration for many of us, and he will remain in our hearts forever. Really, I didn't listen to him sometimes, and I did on my own sometimes as his student. But what I would like to say that now I try to ask him for advice in my heart and in my mind, because he was always right. And I like this picture very much, with which our dear colleague, Associate Professor Maya Kuligina, sent me. This picture was made on the cruise ship of the Volga River in Russia. And Professor Peter Morozov was always wise to know which way to go. And we hope that we will go the right way in the next years and in the future and tomorrow. So this is our international and interdisciplinary team, and we are really glad and proud that we have people with different who work with different specialties, disciplines, and we would like to build up really a dream team with good communication, with good collaboration, with understanding each other. So we have psychiatrists, psychotherapists, and specialists in neurology and clinical psychology, laboratory diagnostics and genetics and pharmacogenetics, immunology, neuroendocrinology, neurobiology, and also we have people who work very good in very good way in statistics and research design and pharmacology and even IT, information technologies, which help us to build research projects in this interdisciplinary paradigm. And it's very important because my talk is also devoted to this interdisciplinary approach in psychiatry, when psychiatry meets linguistics. And this is our key project. We follow now this innovative neuropsychiatry research bank, and we have different project initiatives, including creating digital research protocols, and also we use transcranial magnetic stimulation. And thank you very much for this outstanding lecture delivered by Sujit. And I think we would be happy if Sujit would agree to collaborate with us on our first steps in transcranial magnetic stimulation regarding bipolar disorder, and in particular bipolar depression, because my question to Sujit was, who are those 7.7% responders among bipolar depression patients who respond? So we now work on dynamics and of inflammatory markers as well, and pharmacogenetic issues and markers as well. And we study endophenotypes of bipolar disorder and schizophrenia spectrum disorders, those who are responders to different sorts of and kinds of treatment. And research I'm going to talk today and to put the key message today is related to the initiative of schizophrenia cognitive endophenotype, which we elaborated together with the University of Western Australia, and as well as language of mental disorders, because we study linguistic patterns of depression, dementia, and schizophrenia. Together with Israeli, Australian, and Russian interdisciplinary team of linguists, psychologists, and psychiatrists. And it's a bit about our center. We have also collaboration with different associations. And yesterday, Professor Subodh kindly delivered his lecture about education. And we collaborate with Subodh, and we have official memorandum of understanding signed between our institutions and with the Russian institutions as well. But what is important, we are based now, finally, we are based at the Samara Regional Clinical Psychiatric Hospital, and we have more than 1,300 beds. So we have full access to our patients to study, research them. And we also have the project of ICERN Web Library of Neuropsychiatry, and maybe we would be happy to share the lectures of the Global Psychiatric Association at our web portal, and refer to your website and advertise your website as well as the journal. So this is the Psychiatric Hospital and recent opening ceremony. And we also collaborate with Professor Florence Thibault on women's mental health, but what we would be talking today about schizophrenia is mostly affect male population as well. And also with the WHO, we are the supporter of the Pan-European Mental Health Coalition, working on transforming, on the working packages, transforming mental health services and post-COVID consequences. So finally, after many words, I move to the key issue of my talk, and the key questions I'm going to follow to remind all of us what kind of the disorder schizophrenia really is. Why do we need to pay attention on the language impairments, a so-called thought, language, and communication disorder, and words spoken by our patients with schizophrenia? And what does the decline in action-related language tell us about schizophrenia, and which actions should be particularly done to treat schizophrenia as a linguistic disorder, language disorder, as some groups of researchers consider to develop? So what is schizophrenia? When we're talking about schizophrenia, we're talking about schizophrenia spectrum disorders. And as Spence wrote, it's one of the most extreme states that human beings can inhabit. ICD-10, you can see this in the text, describes schizophrenia as a fundamental disturbance of personality involving its most basic functions, which give the normal person a feeling of individuality, uniqueness, and self-direction. That's a very interesting, how to say, sculpture monument, which is can be found in the corridor of a clinic in Munich, where Kraepelin worked. So this is how, this self-direction and this basic function can be disintegrated in schizophrenia, metaphorically. Schizophrenia is not a disease in the strict sense, but appears to be a group of diseases. And therefore, Bleuler said we should speak about schizophrenias in the plural. As my teacher, Professor Assoc, also prefer to emphasize, to specify, schizophrenia is not a nosological monolith, but rather an assembly of syndromes structured into relatively distinct subtypes of disorder. So when we are talking about schizophrenia, we're talking about subtypes and the phenotypes and heterogeneity of schizophrenia. The course of this disorder, a group of disorders, is not inevitably associated with deterioration. We know that around approximately 60% of patients had multiple episodes with complete or either partial remissions, while only 30% experience continuous disabling illness. And we all know this big study, epidemiological study, which has been supervised by WHO, and Professor Assoc and Professor Norman Sartorius led this multi-center research. It discovered that more than half schizophrenia patients eventually attain a symptomatic and functional remission, and the duration of psychotic symptoms in the first 2 post-onset years is a predictor of symptoms and disability at 5-year and 15-year follow-up. However, the findings related to social support, daily living, and community functioning, that is what really causes serious concern. Around 80% of patients are unemployed. More than 60% report difficulty in socializing outside their homes, and 30% living alone. Also, this feeling of loneliness, which is related and proved to be related to cognitive dysfunction and social isolation, experienced by many of patients. Yes, indeed, 30% live alone, but half and more than half of schizophrenia patients experience the subjective feeling of loneliness, disruption in communication. And if you remember Henry A., who defines schizophrenia as a chronic psychosis characterized by a process of mental breakdown, that can be called dementia praecox, intrapsychic discordance, or autistic dissociation of personality. Schizophrenia is characterized by the manifestation of a deep tendency to stop constructing one's own world in communication with the other, to disrupt the communication, to get lost in autistic thought. And maybe this is the target we should focus on when we discuss this thought language and communication approach, treatment approach in schizophrenia as one of the key targets to socialize our patients and to improve their quality of lives. I also like this paper by Stephenson and Helen Stephenson and Joseph Parnas, who's famous for his papers in clinical psychopathology, when they describe the self-disorders in schizophrenia. And they describe subjective experience of patients who say that they're losing contact with themselves. And the self-disorders could be presented with the disruption in self-monitoring and excessive self-monitoring, self-alienation, self-defragmentation, self-deprecation, self-doubling, and self-reflection. And I like this citation very much. It's the wordings, statements from patients, except from patients' speech. When I'm with others, there are two eyes. The eye who is among them and the eye who objectively looks at this eye. No matter how much I'm absorbed in something, there is always an eye that looks on from the outside dispassionately. This latter outer self is always managing and controlling me. Even when I talk with others, the outer self listens to their words and tells them to the inner self. After listening to this, the inner self starts to talk. The inner self speaks what the outer self commands it to do. And in this citation and these statements, we can recognize the symptoms of thought disorder, the symptoms of auditory verbal hallucinations, and other symptoms which are related to thought, language, and communication disorder in schizophrenia. So the patients suffer from this inner alternation, which is almost impossible to verbalize clearly. But the key point is, as we can see, that they're losing communication with others and losing contact inside their own. And also, very interesting paper published by Boricius about subjective experience of the patients we should pay attention to. Negative symptoms, case symptoms, as Blailer and other psychopathologists emphasized, which are the case symptoms of schizophrenia, the basic symptoms, while psychotic symptoms are just the secondary to these negative symptoms. Core symptoms of schizophrenia. Well, we can see this even in patients' verbalizations. So we are talking about a lack of insight, but we can find these difficulties which our patients experience in what they say. So this, what I emphasize here, the slide, the stuck in my thinking, brain paralyzed between fear and love, stuck on you, stuck between the last word and the next. So blocking, the symptom of thought blocking. Stuck by confusion, the inability to proceed any further in understanding of speech. So again, thought and language. Well, I'm just stuck again. It's very interesting, really, to find this evidence in patients' verbalizations, which give us the key, what we should focus on in our treatments. And the key point message and the paradigm we follow is guided by psycholinguistic approach, which we develop in our department, and maybe just because we had just paper and pen, and now we have, of course, transcranial magnetic stimulation and reagents for measuring genetic markers. But previously, it gave us opportunity to study patient speech and to think more about linguistics. The paradigm we follow is guided by psycholinguistic approach. As I say, it's equally important to pay attention and listen to what patient speaks about and to how it's spoken. And there were different studies we managed. I told you that we managed to study on depression, when we found that patients with depression use, for example, verbs in past tense more often compared to future and tenses and present tense, and use more personal pronouns, focusing on their state. But what is related to schizophrenia, our project in collaboration with Israeli colleagues, you can see here, Jonathan Fine, unfortunately passed away, and Professor Joel Walters, professors of the Department of English of Bar-Ilan University, and here you can see Professor Haim Robert Belmaker from Ben-Gurion University of the Negev, and Professor Yulia Bersutsky and Professor Vladimir Lerner, who are bilingual in maybe trilingual, multilingual, in Hebrew, Russian, and English, of course, is international language. And we have been working on the text of Russian immigrants to Israel. And it was very interesting because there were some findings in the clinical team, and there were some findings based on linguistic analysis, but both groups couldn't find what it really meant, those findings. And then we had brainstorming and realized that the second language really could act as a compensatory resource to maintain verbal fluency in schizophrenia. And it's very important because studying second language, foreign language, could be a resource for remission in schizophrenia. We dared to say in our research hypothesis. And we also know from published papers and recent papers that it's the same in Alzheimer's disease, that people who are multilingual or at least bilingual, they have the onset of Alzheimer's disease dementia later in 4.2 years. And we published our paper about this verbal fluency effect. And also we published a chapter which is available online now, and the ResearchGate, and we described there how schizophrenia is represented in bilingual brain in both languages, and also how bilingualism can affect the course of schizophrenia and be revealed through the symptoms of schizophrenia. And everything is done through the conversations, through the via communication between psychiatrists and linguists. And I just remind you about neurobiology of the language. And of course, everyone knows from students' years about Broca's area and Wernicke's area. And of course, it's much more complicated what's going on in the brain, not just these language areas, which have been described as Broca's areas, which helps in producing coherent speech. And we have incoherent speech in schizophrenia, and Wernicke's area, which helps in speech processing and understanding language. And our patients fail in pragmatics and semantics, and they have failure in understanding the real meaning of the message in social communication. So Ellen Chaika, if you read this very impressive paper, she was a linguist who described the case of a schizophrenia patient. She said that language disturbances in schizophrenia remind some sort of intermittent aphasia. And of course, there are many things we can say about neurobiology of language, and many areas to mention, and there are different models and networks which are responsible for spoken and written language, and it's different in monolingual and bilingual and multilingual brain. And if a person's suffering from schizophrenia, it's much more difficult to explore and to understand what's going on. But what is important, maybe really, we can see some vulnerability of fragile left hemisphere, left brain in right-handed persons. And if we see this brain from the bedside view, the language, speech areas, related areas, thinking and understanding the context, as well as social communication and ability to learn behavioral patterns, mostly related to the left hemisphere and right-handed persons. So the basics of neurobiology of language is that grammar and syntax, so how we build sentences, statements, and use words, are based on Broca's area and acquisition of phonosemantic component on Wernicke's area, while lexical and semantic processing is associated with activation in temporal and temporoparietal regions, including the medial temporal lobe. Retrieval of lexical and semantic data leads to activation in anterior prefrontal cortex, so that according to the declarative procedural model, the mental lexicon depends on declarative memory with the temporal lobe, whereas the mental grammar involves procedural memory and is rooted in the frontal cortex and basal ganglia, which we know impaired in schizophrenia according to neurobiological findings, so postmortem findings. And we know the symptom of difficulties in lexical access, which our patients express subjectively, and we find it in an objective way. And it's also related to what we state here. Verbal fluency is normally associated with the left inferior frontal gyrus. And some difference in bilingual and monolingual brain, which I would like to emphasize, that weak second language is processed through brain mechanisms that differ from those underlying first language, native language processing. And Broca's area is the language organ only for native languages. And when a person speaks 2 or more languages, everything is already different in the brain. And it depends on the level of language acquisition and the age where the language has been learned, acquired by a person. And it depends how neural networks are interrelated and how hemispheres are interconnected, related to language processing and language understanding. And also very important to pay attention on anterior parts of the left prefrontal cortex and the anterior cingulate cortex, which are involved in second language processing. What is also interesting that the brain impairment in schizophrenia is represented in frontal cortex and other areas in left hemisphere as well. At least it have been emphasized in the series of studies, but the researchers discuss, of course, neurobiological evidence on specific deficit in left hemisphere for schizophrenia have been, and left dorsolateral prefrontal cortex have been mentioned in many studies. And the brain impairment in schizophrenia, yes, we should focus and we should focus our attention on the failure of hemispheric dominance for language concept, which describe decreased cerebral lateralization, structural and functional asymmetry, and the distorted interhemispheric connectivity, and other phenomena which can be corrected when a patient or when a person speaks several languages, for example, or is involved in so-called action language therapy, action language treatment, language exercises, not only cognitive rehabilitation, not only cognitive behavioral therapy, not only cognitive remediation, but also particular language remediation therapy. That's what we are thinking about, this particular approach to be able to treat schizophrenia patients. Dorsolateral prefrontal cortex dysfunction is one of the key paradigms related to cognitive disruption in schizophrenia. And this is our paper, which has been published with the team guided by Professor Assoc and the Oxford graduate Professor Joanna Badcock, really experienced psychiatrists and clinical psychologists. We studied fluency deficits in schizophrenia spectrum disorders on the basis of Western Australia family study of schizophrenia data set. So we should think about subtyping and the phenotypes of schizophrenia, because schizophrenia is characterized by variability of clinical phenotypes and extensive genetic heterogeneity, as we already said. And despite the hundreds of years of research described first by Blurler and Krepelin, the multifactorial causes and biological underpinnings of schizophrenia and related disorders still poorly understood, and maybe the language could be the real key to understand it, and thought, communication, and language and internal speech could be the key to understand etiopathogenesis, etiopathogenetic mechanisms of schizophrenia. And this is the phenotype research, which is followed by several groups, and one of the group in the University of Georgia, supervised by Brad Clements, and this study has been funded by National Institute of Mental Health in the United States, which led to the notion that multiple biological pathways can lead to similar symptoms, and we need to study biological underpinnings and those biotypes which can predict the disorder course and outcome. So which patients respond to psychotherapy, which patients, which cohort category of patients respond to transcranial magnetic stimulation and this sort of kind of methods, and which patients should respond to dopaminergic drugs. So it would be efficient to know in advance who is responded to any sort of treatment, and we dream about finding markers, biomarkers, including language markers, how to subdivide these patients' cohorts and to treat them right from the beginning, not to allow the course of the schizophrenia to be bad, to lead them to devastating consequences. And one of the groups of endophenotype research is based in Western Australia, supervised by Professor Assoc, and I was lucky to win this fellowship and to work for 3, even more years, if we include remote work as well, under the guidance of dear Professor Assoc, the former director of the Center for Clinical Research in Neuropsychiatry. He moved from Bulgaria to Perth, Western Australia, and got funded for this extensive research. They have everything, blood samples bank, the wide variety of psychometric measures, investigation of family members, and everything stored over 25 years. So it was amazing, and we had access to linguistic data to study, for example, action fluency test in this big cohort of patients. And really following this direction is what we are now doing in Russia. We have this bank of research when we collect different data from our patients, including biosamples and linguistic data in Russian-speaking patients to compare languages as well. Cognitive and the phenotypes, it's very important. That was, and I just remember you this concept of endophenotypes which are associated with illness, but not part of the diagnosis per se. They have hereditary nature, and we can find the disturbances of language as well, thought, language and communication disturbances in families, in relatives of schizophrenia patients, and it expressed through any language you talk. So no matter where you live, no matter which language you speak, we can find these disturbances, this decline in language and the thought and communication of our patients suffering from schizophrenia spectrum disorders. And what really it was the study based on Western Australia Family Study Schizophrenia database. They found this at least two pure types, cognitive deficient and cognitively spared, and they especially been different on language and verbal related psychometric measures. And still the diagnosis remains primarily based on symptoms, self-reported subjective experience, like everything in psychiatry. And yesterday, Professor Norman Sartorius told us that when we speak about this phenomenon of horizontalization and we speak about the layers, social layers, it was the difference in diagnosing schizophrenia proportionally to this level of difference between doctor and patients belonging to different social layers. And so the language and speech are the primary source of data for psychiatry, both to diagnose and to treat mental disorders. So if patients are mixed up with language, so we need to help to go back to healthy language. We hope so. So if epigenetic works, maybe we can affect again through external factors to treat the disorders, in particular schizophrenia. And Wolfram Hinzen is one of the famous linguists who was originally from Spain, but worked in England, in UK. He had several grants supported the linguistic hypothesis of schizophrenia, and he emphasized that all these positive symptoms, including auditory verbal hallucinations, formal thought disorder, and delusions, are also lie in the language-mediated underlying language-related neural circuits. And in a historical point of view, we remember Kripalin and his descriptions of language phenomena, and also Karl Kleist. I would like to remind you of thought disorder and dysphasia and schizophrenia, and Cameron, who mentioned acidentic thinking and over-inclusiveness, and were the approximations, metonymic distortions in patients' language. And Ellen Check, I already mentioned, who said that language disturbances are some sort of intermittent aphasia. And what is important that almost all language levels are impaired, are disturbed in schizophrenia. So speech comprehension, semantics, fluency, complexity, reference failures, grammar, language lateralization. So this is the summary of the main linguistic findings described in the literature. And Nancy Andressen, clinical psychologist and professor in the University of Iowa, she was the first one who introduced the language criteria of schizophrenia to DSM classification, DSM-3. And then we found this in DSM-4, migrating to DSM-5 as the frequent derailment or incoherence of speech. Also ICD-10, you can see on the slide, and then ICD-11, we still have this paucity of speech. And there are different tools which could be used to screen language disturbances in schizophrenia, different domains, including impoverishment, disorganization and dysregulation of language, and Klang scale introduced by Chen, with 17 symptoms put into 3 main dimensions and domain. And this paper I love as well very much, which was written by Timothy Crow, and this paper in 100 words about psychosis, which is the prized Homo sapiens space for language. So when we start speaking, the social reality and mind was duplicated because we have both material world and the world which was named with words. So we're mixed up with language and meanings. And that was what's happening, thinking in the evolution. And actually schizophrenia appeared as a mental disorder in the population. What is already proved across many studies, linguistics, clinical studies, neurobiological studies, that language abnormalities in schizophrenia are genetically determined, and we can find this thought language and communication abnormalities in relatives, but not reaching the symptom level. And it was published on the automated and Menon language analysis that using artificial intelligence and automatic machine learning, a speech classifier can really comprise semantic coherence and reduce usage of possessive pronouns, for example, as linguistic patterns, and with 83% accuracy can predict psychosis onset, because these subtle disturbances in language are already evident in schizophrenia even prior to first psychosis onset and during prodromal stages of the disorder. So maybe even this screening tool which tests the language could also help us to identify groups at risk as well. And I hope I have 5-6 minutes more because I started a bit later. Try to be fast. So language in schizophrenia, the leading impairments still lie in the area of semantics and pragmatics, and if we turn to the normal aspects of conversational speech, so it's characterized by spontaneity. Utterances, statements occur spontaneously, not only as a response to questions, this language speech is fluent, non-fluent speech is halting and laborious, often with poor articulation. So normal language, normal speech is tone-taking. It shares mutual topic. It is characterized by comprehension. So each participant understands the utterances of the other, and it makes sense. So it's not like formal thought disorder. And it's associated behaviors of facial expressions, gestures, body language, which convey conversational information, and which is disrupted in schizophrenia. And what we focused on in our study was the fluency test, because we found that the poor fluency and deficit in fluency have been recorded in many studies. And by the way, recently we published a review on TMS efficiency, and we found those who were responders, they have dynamic in language tests. It also could be maybe one of the answers for the question, who those patients who respond to this or that treatment in psychiatry, neuromodulation, neurostimulation, etc. And so we focused on fluency of our patients, and we elaborated we studied the information about deficits in action planning, which our patients with schizophrenia experience, and we focused on this research which proved that schizophrenia patient experienced damaged action fluency, in particular, not only phonological and semantic fluency, but action fluency and poor verbal fluency, which was related to the reduction in semantic memory store. So problems with managing meanings. And we studied this decline in verbal fluency, which is a characteristic finding in schizophrenia involving combination of mechanisms, including semantic processing skills, difficulties using context, so pragmatics, and executive dysfunction. And a semantic fluency deficit has already been previously proposed as potential endophenotypic marker in schizophrenia. But the majority of previous studies have focused on object words, nouns, in the semantic fluency task rather than action words, verbs. So we studied action fluency deficit in a previous study supervised by Joanna and Assoc. They proved that it was related to the symptoms, clinical symptoms of odd speech and constricted affect, which is important for communication and increased social anxiety, but not to hallucinations or delusions. So it's some specific construct. And we use this action fluency task, which is very easy, just 1 minute, 60 seconds. You need to ask patient to say as many verbs as possible, as many words that describe actions. And it's important that verbs, that patients with frontal lobe injury, for example, demonstrated verb retrieval difficulties, but retrieve nouns at normal levels. So it's different in the brain when you retrieve verbs versus nouns. So different areas are damaged. And we will find that action fluency is declined, verbs decline. It's related to specific region and specific functions. We can target in our treatment strategies, across our treatment strategies. And the meaning of action words and actual movements activate motor and premotor cortex. And this rules out as specific unified meaning center. And you can see across different studies, there's face-related words, arm-related words, and leg-related words, as well as pronouncing verbs related to these actions, to the appropriate actions, activate the same, almost the same areas in the brain, movements and action words. So we move inside this topic scientifically deep, actually, and we also put into the focus the hypothesis that there is some cortical connections related to action words, recognition and comprehension, and there are specific semantic connector hubs which are related to category specificity. And it was an interesting paper published in Nature, Semantic Atlas of Cerebral Cortex, which suggested that topographical differences in brain activation are driven by word meaning, action versus object semantics, rather than grammatical class per se, so not just verbs versus nouns, but the meaning of the verbs. So it's possible that some particular verbs are damaged, impaired in schizophrenia spectrum disorders. So we studied abstract versus concrete constructs and high motion versus low motion verbs. And what we really did, we classify all the verbs we had from this action fluency task from Western Australian Family Studies Schizophrenia. And we studied different characteristics, lexical characteristics like word length, word frequency, and valence. You can't imagine, but there are corpora of data which have been elaborated in Oxford and Cambridge, and which has all this data on every English word and verb in particular. And so all these aspects, all these parameters can influence words, verbs, retrieval, and comprehension. And what we found when we analyzed our data, comparing the study group and the healthy control group using this action fluency task, you can see here the example of action fluency, schizophrenia and action fluency in healthy control. You can see the deficit, definitely. And we use the classification, English verb classes and alternation developed by Beth Levine, the Stanford classification of verbs. It has 48 classes, but we grouped them into two superordinate semantic categories: action verbs and mental state verbs. Verbs which refer to concrete observable actions, which are strongly related to specific body parts or regions, and mental state verbs, which are defined as verbs whose meaning related to understanding, discovering, planning, or deciding, such as know, feel, and believe, for example. And what we found that in patients with schizophrenia, action verbs suffered more than significantly more than mental state verbs. There is significant difference between schizophrenia spectrum disorders and healthy control related to action verbs production. And also when we specified this cognitive deficient phenotype and cognitively spared subject, it was also a trend and a significant difference. So what we found within the whole sample compared to mental state was that the action verbs generated were characterized by a shorter word length, lower word frequency, and earlier age of acquisition, and higher concreteness ratings, but didn't differ in valence, in lexical characteristics. But what is important, that action-verb fluency deficit was correlated with the interpersonal domain on schizotypal personality questionnaire. Domains such as social anxiety, no close friends, and constricted affect, and with immediate and delayed recall scores on the verbal learning test. And I will just summarize the findings. The aim of our study was to investigate the specific features or region of action-verb fluency impairments in schizophrenia. And we analyzed the verbs output in schizophrenia patients compared to healthy control using this specific cognitive linguistic approach, interdisciplinary approach. And we studied semantic categories, action versus mental state verbs, and their lexical characteristics, which really affect the production of every type of verb, and correlations of these parameters with cognitive and clinical features. And what we found that the proportion of action verbs suffered in schizophrenia compared to healthy controls and compared to mental state verbs generation. And it was not due to an effect of medication, because we studied correlation with clozapine, those components. It was unrelated to the fluency. It was not due to poor reliability of semantic categorization, because we have iterated reliability with several linguistic groups, anonymous analysis of all these data sent. And it was not due to lower intelligence of education of our schizophrenia patients, as we also proved, and not due to verb difficulty effect, because mental state are more difficult than action verbs, and they are acquired later in age than action verbs, but they didn't suffer in schizophrenia. Action verbs suffered, and not due to age-related decline, as I said. So we found this specific action verbs related deficit. And we found this greater difficulty integrating verbal and perceptual semantic representations associated with the concrete meaning of action verbs in schizophrenia patients, which because of this precision of encoding or reactivating perceptual memory codes. So it's related to memory and meanings in the memory. And what we would like to say and develop further is the study about, we're interested whether the degree of sensory motor impairment could predict the action verb fluency deficit in schizophrenia patient, in line with the classical theories of embodied cognition. And this action fluency test can already show us the language pattern, both in patients and relatives, as we now see in our cohort of Russian speaking patients. And what was the finding? I would like to say once again and emphasize that it was an indicator of poor interpersonal functioning. And we found the increased sense of psychological distance from others related to this action verb fluency deficit, proved revealed in our patients, observed in our patients. And this points to specific relationships between action-related language, memory deficit, and poor interpersonal functioning in schizophrenia spectrum disorders. And what we would like to implement the intensive language action therapy is as one of the part of cognitive remediation, or separate linguistic language remediation treatment, where the patient can use action verbs and in the specific linguistic exercises, and when can patient move and communicate with reality. So this what Henry A. said about schizophrenia: stop communication with others, stop communication with reality. We need to learn, we need to teach our patients how to interact with reality, also via learning verbs and training verbs production. So the message is to spread the word about linguistic paradigm related to mental disorders and to take an action to treat schizophrenia. Don't doubt, but do. Doubt is a mental state word, but do is mostly related to the action. So thank you very much. And for collaborative words in action, there is an email here, and we would be happy to collaborate. And maybe for the global psychiatry archives, maybe we can dream about a special issue on a linguistic approach for mental disorders. I'm very sorry for being late and for too many words. I hope I will act more in future.
Thanks so much.
Thank you.
Thanks so much for this, and you're very much invited to organize a special issue on linguistic schizophrenia and certainly action, because I think that's the most important part. One of the things maybe, I don't know if there's other questions, I'd like to know where do these, very often, where do these, we call them neologisms come into this, so I think